Thank you very much for this invitation. It's a great pleasure for me to be here and great privilege to take part in this session. I'm here to present the study which is entitled Impact of Responsive Insertion Technology on Reducing Discomfort During Colonoscopy. It was a randomized clinical trial that we have made in Krakow, Poland, with my colleagues from the Jagiellonian University Medical College. There are no disclosures regarding all the authors of this study. Let's start from the definition of responsive insertion technology, which is a unique combination of three technologies, the so-called passive bending, high force transmission, and variable stiffness. These technologies work together to improve ease of insertion and operator control, which may help to minimize patient discomfort and enhance procedural efficiency. Passive bending helps endoscope move through acute bends in the colon, as the passive bending section is located between the insertion tube and the conventional bending section of the endoscope, as it is here marked on the blue section. When the scope meets with resistance, the pressure is redistributed so that the insertion tube automatically bends to adjust to the contours of the colon, potentially decreasing patient discomfort and speeding insertion to the cecum. High force transmission provides improved operator control for pushing and twisting maneuvers whenever the scope is pushed forward or rotated. The pushing force or rotational torque is transmitted in a one-to-one manner down the length of the insertion tube, meaning the scope reacts more sensitively to physician handling and is easier to maneuver within the colon. The variable stiffness allows the flexibility of the scopes to be changed incrementally by manipulating a flexibility adjustment ring that ranges from 0 to 3. This innovative feature allows the variable stiffness colonoscope to be adjusted on a case-by-case basis to meet the unique anatomical needs of the patient and the handling preferences of the physician. The aim of our study was to evaluate the cecal intubation time, the rate of loop formation, the requirement to apply maneuver pressure to different areas of the abdomen, and degree of discomfort and pain expressed on the visual analog scale. This is the consort diagram that presents the patients that were enrolled to the study. Approximately 1,000 patients were invited to participate in the National Colorectal Cancer Screening Program and were invited to participate in our study also. We qualified 647 patients who underwent complete colonoscopy, and approximately half of them was enrolled to group 1, in which we use RIT technology, and the rest of them consisted the group 2, which was examined without RIT technology. All colonoscopies were performed without sedation because in Poland we perform the main load of colonoscopy in such a fashion. We used the endoscopes that were equipped with magnetic positioning system. Group 1 included patients that were examined using variable stiffness endoscopes equipped with RIT, and Group 2 were examined using conventional variable stiffness endoscopes without RIT. And the results were the following. The complete cecal intubation rate was 100% in both groups of patients. The cecal intubation time was significantly shorter in the responsive insertion technology endoscope group, and it was measured as to be 209 seconds versus the conventional endoscope group, in which it was measured as to be 224 seconds. It was statistically significant. The number of undesired loops in the shaft of the flexible scope was significantly reduced when the RIT endoscope was used. The total frequency of abdominal compressions applied by nurses during endoscopic insertion was also reduced in group with RIT technology. Similar findings were noted concerning the need to change the patient's position on insertion of the endoscope. Finally, the abdominal pain was assessed using a 10-point visual analog scale. We observed a significant trend of reduced pain in patients in whom colonoscopy was performed with responsive insertion technology. It was statistically significant. Let me pay your attention to these pictures that are taken from the scoped guide view. This picture above and to the left shows us the conventional variable stiffness endoscope as it is passed through the left splenic flexure, and we can see that the acute angle is made through the flexure. It evokes painful syndromes during colonoscopic insertion, but in contrast, at the bottom we have the picture that presents variable stiffness endoscope equipped with RIT function, and it means that we have the passage of the endoscope that is mild through the splenic flexure. The acute angle is not visible like it was without RIT function. And in conclusion, the implementation of RIT reduced the cecal intubation time. The modified structure of the endoscope made the colonoscopic examination easier by reducing loop formation upon insertion with subsequently reduced rate of auxiliary maneuvers. And finally, colonoscopy with RIT significantly reduced discomfort in unsedated patients. Thank you very much for your attention.